Hi, I'm David Ridley. My guest is Dr. Mark McClellan. Dr. McClellan holds doctorates in medicine and economics. He led the Food and Drug Administration and the Centers for Medicare and Medicaid Services. He now leads Duke University's Margolis Center for Health Policy. We're really lucky to have Mark as a colleague. Welcome, Mark.
Hey, David, great to be with you and great to have such a good partner in our work with the health sector management program at Fuqua. I think we're the only health policy center that's actually physically located in a business school. Not that physical location really matters all that much these days. It just kind of highlights how important it is to make progress in healthcare, to have collaborations and innovation that brings together the public and private sector. So it's been great working with you and looking forward to future opportunities as well.
Likewise, Mark, you've been an amazing colleague. You and your team at the Margolis Center have certainly made us better in health sector management at the business school.
Mm-hmm.
Mark, what leadership advice do you have for the incoming heads of the FDA and Medicare, given that you used to lead both of those?
Well, I guess I'd start out by saying take a deep breath because they definitely both have full plates. The agencies are a bit different historically and culturally. The FDA comes out of the nation's Public Health Service Act regulatory bodies, along with the Centers for Disease Control and other public health programs. And it's been around for a long time and has a great tradition of having regulatory approaches based on the best and latest science. The best thing about being there, David, was you have the fire hose coming at you every day of everything going on in science that matters to human beings, and to say animals too, for that matter. To also regulate animal products and most of the food supply. So it's a very busy agency, and one where management, it really requires listening a lot to the staff and making sure that you're upholding that principle of science-driven regulation. That creates predictability for everybody. It means that there are going to be standards. No matter what you do every day, there'll be decisions that people disagree with you on. It's actually pretty liberating, so you can kind of go in and do what you think is right, because you're going to get criticized no matter what you do. Too fast, too slow, not enough regulation, et cetera. But really making sure there's an empowerment of science-based regulation. It's sort of best for industry and certainly best for the public in the long run. We saw some challenges in that in the past year. For the FDA commissioner now, we've got an acting commissioner in Janet Woodcock, who's terrific. Anyone who comes into that job, is their first and foremost responsibility is going to be helping to respond to the pandemic. And we still have a lot of challenges ahead for the agency in finding creative approaches where you have to balance, and it's all about balance, speed and response, and being thorough, addressing safety and effectiveness issues. And we can talk about a little bit when it comes to vaccines, when it comes to therapeutics. You think about a pandemic as, by definition, at the beginning at least, you have nothing that works. So it's a complete unmet medical need. And the COVID-19 pandemic is an unmet medical need at a scale that we haven't seen in, a century plus. So big job for who's coming in. I think just keeping the focus on the science, but really being creative and forward-leaning and finding innovative ways to develop and update products, and making sure that vaccines are reflecting the latest variants, et cetera. It's a very challenging job ahead. And on the CMS side, look, it's the nation's largest agency by far. It's going to spend probably $1.3 trillion plus this year, including a lot of flexible, innovative approaches for helping providers deliver services under circumstances that people weren't even imagining a year or so ago. And compared to the rest of the entire Department of Health and Human Services, the whole rest of the department only spends about less than $100 billion, maybe a bit more now with the pandemic response, but just really critical for where our healthcare system goes. And its tradition is different. It came out of a paying accurately tradition. It was part of the Social Security Act legislation. So Social Security Agency is originally called the Healthcare Financing Administration. So its history was much more kind of top-down structured. Let's pay right, let's pay efficiently, let's pay on time. And that agency has had to undergo some big changes in the last few decades as the way we pay makes, and especially the way that agency pays, since it's so huge, makes such an impact on the way that healthcare works, what kind of products get developed, how care gets delivered. So it's actually having to become much more of a public health agency, even though that's not sort of its original DNA. And I think some of the big challenges in running CMS, aside from just its massive size and impact on the healthcare system, are recognizing that it is, in many respects, the nation's most important public health agency from the standpoint of how healthcare is delivered because of how it pays, making such a difference.
Mark, that was a really helpful history lesson to think about the history of these agencies and what that means for their behavior today. And I liked your positive spin. That was your positive spin was, look, at FDA, you're going to be criticized either way. You're either too fast or you're too slow. You're going to be criticized. So it's liberating. You can just do the right thing. I love that perspective. So you also mentioned the pandemic. Of course, we're living in the coronavirus pandemic. What do you think was the biggest healthcare leadership mistake of the coronavirus pandemic?
Oh, gosh, David, when we look back on this, there are going to be entire commissions. There already are some books being written. So people are going to find a lot of things that could have gone better. I'd put two at the top of my list, and they're both kind of generic that span across a number of different areas. One is, when you're in a pandemic, you're always behind where you think you are. So, what you're seeing in like hospitalizations or even cases today reflect behavior that happened before. The scale of things that you're operating against is smaller than what the actions you take now will actually make possible. And there were some decisions along the way where, in retrospect and probably in prospect, we should have done something more proactive. Just to give one example, back at the beginning of the pandemic, when we knew that cases were starting to spread in China, and you saw the big surge in Wuhan, and in January, cases started to appear in other parts of the world. The US was a bit slow in really upgrading its capacity for doing testing to detect the virus. And we are now living in the total synthetic biology age of responding to pandemics. Even though China was withholding some information early on about cases and sequencing and the like, we actually had a sequence of this virus circulated very beginning of the year. Our colleagues at Duke, National University of Singapore, made the first lab test, so-called PCR test, to detect the virus like the second week in January. And those tests started to be used early in places that had been hit hard by pandemics that people got behind, including Singapore with SARS, the earlier coronavirus back in 2002, when I was at 2003, when I was at FDA. In the US, we didn't quite learn that lesson. So we didn't have those tests available right away. CDC wanted to work on their version that they thought could be, even better, more sensitive, more precise than the ones that existed. They had some challenges with it. We didn't really enlist the hospital-based labs in a proactive way. And for a pandemic that turned out to be as bad as this one in terms of spread of cases by people who aren't symptomatic, that really put us behind. So when we did start doing testing, and actually some of it was done by Trevor Bedford, University of Washington, as part of a surveillance network that basically went around the CDC and restrictions, and FDA not approving any of these so-called lab developed tests early. They started finding cases in Seattle. Well, we did respond after that, so testing became more available. But by that time, we had already seeded a lot of the country, and we've been kind of behind on testing ever since. And so just being very proactive, doing surveillance effectively, is so important, especially now that we've got the capacity to make diagnostic tests and therapies, for that matter, using synthetic approaches like mRNA technology or monoclonal antibody technology that enable a much faster response to pandemics than we've ever had in the past. And I guess the second challenge, since you only asked me one, I'll give you two anyway, is we did get off of a straight kind of public health response line for this pandemic. And I don't want to go into too much detail on the politics of that. But unfortunately, we had ended up having many of the public health responses being viewed through a political lens, people thinking of things like mask wearing or taking other precautions as issues first and foremost of individual liberty, rather than the individual support for what we need to do together to get through a pandemic. I think we're still working through that challenge now. I hope in the future that we'll be able to get public health back to the issue of freedom that it really is. It's our decisions do impact those around us, and my hope is that going forward we can get more consensus around ways in which we're protecting individual liberties, but things like mask wearing and distancing, people will differ on that. I know it's harder for some people to follow than others, given their jobs, their preferences and all, but I'd like to see it much more back in the public health and not the political realm.
Well said. I'll tell you what I heard. I'm not claiming you said this, Mark, but what I heard was the CDC should have done better, and we shouldn't have politicized masks so much.
Well, that's among the issues, but I think it's that those are reflective, David, of some more, significant issues of getting behind. So, even today, our test supply is really ramping up. Well, it would have been helpful to have enough tests if we had ramped up supply back in the spring and summer of last year. We could have probably done a better job with containment. Again, that's back to my point of just you're often in pandemics behind where you think you are. You need to think a sort of an order of magnitude ahead on scale. And even though we've been through a number of pandemics where shortages always result, we've seen it over and over again. So testing, PPE, protective equipment, lab capacity, et cetera. Now vaccines, although I think we actually did a pretty good job on vaccines, all are areas where it's just really hard to keep up.
You mentioned we did a pretty good job on vaccines. Can you tell me about what you see as some successes in government policy during the pandemic?
Yeah, I think what we did on vaccines, David, actually is a model for what would have worked if we can apply the lessons to other areas of pandemic response, like therapeutics and diagnostics and supplies, supply chains and the like. For vaccines, remember, we are now at a point where I know people think we're going slow, but we've gotten probably 35 million plus, we're talking in mid-February, 35 million plus Americans vaccinated. Just a little over a year after this pandemic was first, the virus was first even discovered and the pandemic began. That is 5-6 years less than ever has been achieved in terms of the time course for developing prior vaccines. And it's a function of the fact that we have technologies that we didn't before. The mRNA technology has been around in some form for a decade, but this idea of being able to rapidly identify the virus, as I was talking about earlier, and then synthesize an mRNA, a substance that it can be part of a vaccine, manufactured rapidly, goes into your body, manufactured by your cells into pieces of a virus, not harmful in themselves, but enough to generate an immune response. I mean, we had the first versions of these mRNA vaccines in human testing last March, like 2 months after the virus was discovered. And not only that, instead of making the vaccine development process the usual long, linear, slow, always going to be behind where you want to be process, we took steps to make it kind of hyper parallel. So the same time as the early clinical testing was going on, there are steps being taken to set up large scale testing platforms out in communities, not just in Boston or New York or some of the areas that were hit hard early, but anticipating around the country and around the world, setting up trials that could be done by potentially busy, hard hit health professionals. Remember, you want to be doing these vaccine trials and other therapeutic trials in areas where there are a lot of cases, not a few cases, because that's how you learn the most from the experience of all the people who are suffering from COVID. So we set up a clinical trial network to do that. At the same time, the FDA worked with other regulatory agencies around the world and with its own staff, did some very detailed guidance for what was expected for these vaccines to show that they were safe and effective, recognizing that we're in the midst of a pandemic, but for a treatment that's going to be given to essentially millions, if not billions of healthy people, you want to maintain the usual safety standards that FDA has in place, as well as being confident that the treatment's going to be effective. So all of that clinical development process was set up so that as the vaccines march through the early stage clinical developments, is it safe? Any obvious problems? Does it look like people mount an immune response? Could go very quickly into those larger scale trials. So 30, 40,000 person trials got launched for the early treatments by last summer, so that we had results by fall. And then in parallel to that, lots of large scale manufacturing going on well beforehand. I know, today, we're seeing a lot of people who want to get vaccinated and there doesn't seem to be enough supply for them. But if you think about the way that vaccine production usually works, the production usually doesn't even start until after you finish the clinical trials. That's a lot of manufacturing capacity investment to put at risk. So what the federal government did this time, in partnership with the manufacturers, going in jointly on manufacturing capacity. So at the same time the clinical development was going on, the regulatory pathway was clarified, there were literally hundreds of millions of doses being manufactured, so that between the time that the clinical trials ended, and for Pfizer, that was in November, for Moderna, the 2 mRNA vaccines, late last year, it was only a few weeks to get to FDA emergency authorization after that, for FDA to review all the data in detail, because they knew what was coming. There had been a very clear process set out. And then only within a couple of days after that did the vaccine start getting shipped at scale. Now, that's where things went went significantly off the rails. That very thoughtful process that involved a lot of military management and logistical planning to make sure we're doing manufacturing at large scale and have a distribution system to get the vaccines, which require special treatment or special storage conditions, out to where they're needed fast and in a way that could be tracked. The problem was that the last administration's planning kind of ended there. That's where they sort of turned it over to states. As a states, well, you'll get your doses. Disaster response in the U.S. is a federal state partnership with the federal government providing support and the states on the front line. The problem with that, David, was that the states are also not used to doing anything at nearly this scale. And so, not surprisingly, when the rubber hit the road and the vaccines actually started being delivered, we didn't have local public health authorities that had, telephone or better yet, online or combination scheduling systems in place to manage the demand. And we didn't have scaled locations in place to do the vaccines. So we're working through all of that now. And now I think people would have liked to see us make even bigger investments than the advanced manufacturing that was done. But we are going to catch up with that by a month or so from now. If you look at the vaccine production schedule, also if the J&J vaccine gets authorized and the data looks very promising, there will be an FDA public meeting on that, and that towards the end of February. By the way, I'm on the J&J board, but this is just all public information. Between Moderna, Pfizer, and especially if J&J reaches the market too, and there are a couple of other manufacturers who are also getting this advanced support that I just described, we will have enough doses to vaccinate every adult American who wants it by summer, by June. So that's incredibly fast pace. for pandemics. I know not as fast paced as people would like now, since it seems like, we should be able to get there perhaps even sooner. So we're seeing more efforts to accelerate access, more efforts to accelerate manufacturing. But it's a very impressive increase in speed of vaccine development and availability compared to anything that's ever happened in any kind of pandemic response before. And learning a few lessons from this, David, I think if we could apply that same logic that we put in planning, that we put into vaccine response, into testing response, as I talked about earlier, have plans for identifying the pathogen, whatever it is, ramping up testing capacity so we can detect it early, contain it better. By the way, we made now a lot of progress on rapid tests and so forth. So that's technology that's going to stay with us for the long term. Same thing for other kind of treatments for the pandemic, like monoclonal antibodies. So these are synthetic versions, man-made versions of the antibodies that you make in response to a vaccine. We know how to do those at large scale too. Those can help with people who haven't had a chance to be vaccinated yet, and we've seen that start to happen. But again, in those areas, we didn't do as much of this advanced planning, large-scale production, planning for distribution, and that's, I think, the direction that will hopefully make the next pandemic go much more smoothly than this. We should never have to live through anything like this again, given the medical technologies that are now available and what we should learn from this experience.
Mark, you talked about the rollout of the vaccines, the administration of the vaccines, and the scheduling tools for states. You led the smooth and successful launch of the Medicare drug benefit. When Medicare Part D launched, you were running Medicare. Can you talk in general about what it takes to successfully launch a new government program like this, whether it's Medicare drug benefit or Obamacare, or getting people signed up to get vaccines administered?
Yeah, so it's a great question, David, and basically lots of advanced planning and working with people who know the area really helps. It's nice that you said that now Medicare Part D is remembered as a smooth rollout and a smooth program. I gotta say, it did not feel that way at the time. Remember, this was a drug benefit for every Medicare beneficiary. Then we had, some 40 odd million of them, including a subset of those, 8 or 9 million Medicare beneficiaries who were also on Medicaid. Those are low-income beneficiaries had previously been getting drugs through 50 plus different state and territorial programs, each of which did their drug benefits in a different way using a different information system. And these are the most sick, most frail of the Medicare beneficiaries in terms of their health problems. And we're talking about prescription drugs where, you don't want people going a day without a medication. Well, somebody had the good idea of, well, let's start this entire program for everybody, all close to 40 million Medicare beneficiaries, including the Medicaid switchover, on a holiday, January 1st, 2006. And, we did a ton of prep work, including, and I'll give President Bush at the time credit for this one, or people saying, well, if you're going to really put this program in place, our team said we need to tell people, the drug plans, the pharmacists, the beneficiaries, the state groups that work with the beneficiaries, exactly what we're doing well ahead of time. If you work back, that meant in early 2004. Well, 2004 was an election year. And so, some people, not surprisingly, were saying to the president, well, there are going to be controversial features in this. They're not going to cover every drug. There's going to be some pricing and, negotiation leverage that's going to come from setting formularies. Let's just put that all off, all the hard decisions, till after November. And I remember making a very strong case to him, and he said something along the lines that I was saying earlier, David. He said, hearing the political sides of this and the needs for us to get the program right, says, look, people are going to criticize this program in an election year, no matter what happens. So at least they'll be writing about my Part D program and how we're trying to get it off the ground. Go ahead, Mark, do get out all the details you need. And so that basically enabled us to really finalize the features of the program and then have a lot of months after the election, after 2004 and 2005, before this really started in 2006, to work out many more kinks. All that said, we still had tons of IT issues and problems of patients not being able to track over all of their prescriptions and coverage into the new benefit. We had to do a lot of work on the ground with every state. The states, we had anticipated this before, said, you all may need to keep providing benefits for people who don't make a smooth transition over to the new system. Keep paying for their drugs. We'll pay you back through a kind of a temporary emergency program. We also had a lot of education outreach to do for beneficiaries. They had to choose among different drug plans, and that was a new thing as opposed to just like one defined benefit. Here it is. But we were able to work through all of that, and it's good to know that people don't remember the bumps and do remember the longer term impact of the program. And it's nice to see that it's continue to have bipartisan support. It is time for an update. Back in 2005, 2006, we didn't even know if prescription drug insurance could exist. It's drug expenditures are pretty predictable, and we had put in a bunch of tools to try to help with that, like risk adjustment and some bonuses related to quality and delivering good service and all of that. And those have largely worked out, but it's time to relook at the benefit. And I hope we can find a good bipartisan, lasting way to do that in the coming months.
Well, I certainly do remember it as a success, Mark. I remember there were a few glitches early. There were some Medicaid patients trying to figure out why they're on Medicare now and which plan they have.
Well, yeah, but you weren't doing the interview with like 60 Minutes or going before the congressional oversight hearing at the time, David. So my memories are a little starker. But like you said, it's this is what happens when you start a big new program. There are going to be things that go off the rails, and you can't anticipate all of them, but you can anticipate the kinds of things that are going to go wrong, and you can be ready to respond. And we had, like I said, I give the president credit for supporting us. Not pulling the plug or anything like that, supporting us on working through those opening kinks.
Mark, the final segment is overrated or underrated. It's a segment I copied from Tyler Cowen. I'll name an item and you'll say whether it's overrated or underrated, and you can pass. Although I want to warn you in advance, there is a correct answer for some of these. The first one, don't get this one wrong, is Star Wars. Overrated or underrated?
Oh, David, definitely overrated. So I am a you may not know this, but I am a Trekkie. So grew up on Star Trek and still have my optimistic view of the future that we're going to get there someday. I think I may be the only person on Sunday talk shows ever been asked to do the Vulcan sign for live long and prosper. So that's the way science fiction should be done, not the Force or whatever that is.
Yeah, I'm sorry, that answer is incorrect. My guess is that your brother might actually give the right answer. And speaking of your brother, overrated or underrated, working for the same employer as your brother?
Oh, yeah, that was great. I got a chance to work together in the White House while he was press secretary. Busy times, but I had young daughters at the time. We could go visit me and brother together. It's like, they thought it was like a little family business or something.
Speaking even more broadly, overrated or underrated, working for the White House?
That was a great experience. I'm sure it depends on the particular White House. My guess is that some of the people who worked in the most recent past administration may have had a different experience than I did. But I've had a privilege of working with President Bush on the Council of Economic Advisors and kind of overseeing health policy from the White House before doing the agency jobs that we already talked about. And he was just, we got to do, we talked about Medicare Part D. We also got to do a lot of emergency response planning post 9/11 with the anthrax attacks. And the other great program to work on then, thanks to his leadership, was PEPFAR. This was a program to bring better AIDS treatments to the rest of the world. And my hope is that that's actually going to be a model, David, for what happens next in terms of vaccine availability. So, and there's a real oversimplification, but in the 1990s, there was an awful lot of advocacy and pressure from groups in the US to make better HIV treatments available here. And not that we solved that problem, but there's a lot of progress in the 90s in antiviral technologies and better management techniques, but they hadn't made it out to the rest of the world. And that's an investment that's just so worthwhile. I think there's a lot to learn from that program that's still relevant now. So, the nice thing about working there is you can kind of get some firsthand experience on how some of these big new programs can come into existence. And, hopefully those kinds of experiences are still relevant today, as we're not going to get beyond this pandemic until we get beyond it for the whole world.
Well said. And I'm so glad you mentioned PEPFAR, the President's Emergency Plan for AIDS Relief. I think that's one of the important accomplishments of the Bush administration, and something that's benefited a lot of people suffering from HIV/AIDS around the world.
Yeah.
My guest today has been Dr. Mark McClellan. Thank you, Mark.
Great to be with you.